Welcome back to Open Med School. I am Dr. Andrews, Professor of Medicine and Consultant Neurologist. Today I'll be discussing a few cases which are critical challenges in emergency medicine, that is hypertensive emergencies. Take case number one. This is a history of a 56-year-old male with a history of uncontrolled hypertension, presents with confusion, headache, and blurred vision. His BP is 240 by 130 millimeters of mercury. Hypertensive emergencies are frequent cause of ED visits and are significant clinical challenges. Traditionally, severe hypertension is divided into hypertensive crisis, urgencies, and emergencies. However, recent recommendations of the European Society of Cardiology, that is ESC, suggest abandoning these terms as they are misleading and sometimes inappropriate. And we should focus more on hypertensive emergencies, which are defined by acute rise in blood pressure associated with target organ damage. Hypertensive urgencies, the difference is that there is a high blood pressure, that is a systolic usually more than 180 and diastolic more than 120 without evidence of target organ damage. Hope this difference is clear. As per this BARC approach, step 1 is identify that the patient has a hypertensive emergency. The criteria: systolic BP more than 180 and diastolic BP more than 120 and presence of one of the acute organ damage. So B for brain, I already mentioned hypertensive encephalopathy, stroke, which can be hemorrhagic stroke, ischemic stroke, or subarachnoid hemorrhage. Arteries, it is aortic dissection and acute coronary syndrome. Retina, malignant hypertension. Kidney can be acute kidney injury, including hematuria, proteinuria, and heart acute left ventricular failure presenting as pulmonary edema. So this is the BARC approach. And again, you should remember that when somebody comes to the emergency department with severe hypertension, is there a known cause for hypertension in this patient, like preeclampsia, aortic dissection, sympathetic crashing, acute pulmonary edema, acute myocardial infarction, transiently producing rise in BP, or a stroke like a vertebral-based stroke presenting with an elevated BP, scleroderma, renal crisis, symptomatic intoxication, hyperthyroidism, uncontrolled pain, or even urinary retention can lead on to rising. So these other causes for hypertension should be looked for, and if present, evaluate for that. If there is no obvious cause is there and the patient meets the criteria for emergency, look for target organ damage. If present, reevaluate for an underlying disease process causing hypertension. Consider CT head because primary intracranial pathology should be ruled out. Evaluate for other causes like dissection, intoxication, especially in the era of drug use. Aggressively treat possible precipitating factors like pain, agitation, substance withdrawal. And again, you see that there is persistent severe hypertension but no clear cause. It is a primary hypertension emergency and IV antihypertensives are indicated. Immediate BP control with using an IV antihypertensive like nicardipine, labetalol, sodium nitroprusside as per the particular situation. And once BP is controlled, you go for a clinical improvement is there, you go for the oral medication and gradually transition from IV to oral. So in this patient, the initial assessment and monitoring, immediate measure history and physical examination, focus on neurological status, cardiac symptoms and renal function. Monitor BP continuously. If critically ill, go for intra-arterial. Definitely take an ECG, look for troponins together, especially if you suspect a cardiac involvement. Fundus should be examined for papilledema. Presence of hypertension with papilledema due to hypertension is called malignant hypertension. A serum creatinine and urine analysis for kidney assessment, brain imaging CT and MRI. In this patient has also headache, confusion, etc. ACT is also indicated. So as mentioned, fundus. This is the showing papilledema, the blood margin. So this is the test. This patient will be having malignant hypertension. An MRI or a CT imaging is MRI here shows cerebral edema without any infarction in the FLAIR images. Step 3 will be immediate IV antibiotic therapy based on target organ damage. So here the patient has got hypertensive encephalopathy, that is brain is affected. The preferred drugs are labetalol and nicardipine. Sodium nitroprusside is not indicated or not advised because this can produce vasodilatation. Avoid rapid fall in BP. The target should be mean arterial pressure should come by 10 to 20% in the first hour. So here the drug of choice will be labetalol or nicardipine. In other situations, the drugs are given. So manage with IV labetalol or nicardipine, reduce BP maximum 25% of the mean arterial pressure in the first hour. Avoid rapid reduction as I already mentioned, as you can prevent hepatitis ischemia. Avoid sublingual nifedipine. Sublingual nifedipine should not be given because of the risk of sudden BP fall. IV nitroprusside, as mentioned, it can increase the internal pressure. Because it produces vasodilation. Then reassess the patient, monitor for BP, target organ recovery, and plan to give oral antihypertensive within 24 to 48 hours and have a long day BP control. So I have mentioned the approach to patient with a broad with severe hypertension or high blood pressure with a casualty. All the elevated blood pressures 180, 120 are not hypertensive urgencies or emergencies. So if the target organ damage is there due to the hypertension, it is hypertensive emergency. Always look for other causes that can present with elevated BP in the casualty. So this is another case, 48-year-old female with chronic hypertension and diabetes presents with decreased urine output. BP is 230, 125. Has got elevated creatinine, urine shows protein. So this can consider as a hypertensive emergency, acute kidney injury, most likely due to hypertension. Look for other causes. In the management, we can go for nicardipine to lower BP while maintaining renal, because avoid AC inhibitors. This is another example, patient presenting with acute pulmonary edema. Again, the BP is very, very high, so acute pulmonary edema presenting as a feature of hypertensive emergency, acute left ventricular failure that affects the heart. So the clinical examination will show bilateral curves and S3 gallop. Management is IV nitroglycerin and loop diuretics because it reduces the preload and afterload. Beta blockers are not preferred, but IV labetalol can be given if there are no contraindications depending upon the clinical setting. Again, go by this algorithm. So we have discussed what is hypertensive urgency, what is hypertensive emergency, and how to follow the patient in a systematic way so that optimal care is given. Thank you.